If Hodgkin lymphoma relapses, eligible patients receive an autologous stem cell transplant after high-dose chemotherapy, and many people are not eligible for this because they might be of older age or they might have comorbidities. So this is an important population that's been difficult to treat historically. We now have the advantage that we have targeted drugs such as Brentuximab, Vedotin, or the anti-PD-1 antibodies Nivolumab and Pembrolizumab approved in this setting. And especially Pembrolizumab, I think, has shown that it is even superior to Brentuximab Vedotin in a randomized phase 3 trial which was published last year. And at least in our daily practice, many of these patients actually receive an anti-PD-1 antibody because it is considered rather well tolerable. One has to be careful with the immune-related side effects, but overall it has a more beneficial safety profile compared to, for example, conventional chemotherapy. And what it also provides is that it often induces very striking remissions, which then might be long-lasting. But also in patients who don't necessarily achieve a PR but a stable disease, this might hold up for several months or even years, providing disease control for these patients. And if this is, for example, an older adult, basically, who receives this treatment, this might be something that's very beneficial for him or her, and therefore I think it's great that we have these options now. And I would try to treat those patients on trials, obviously, but if there are no trials available, we are in the lucky situation that with the approvals over the last years, our toolbox has expanded, and these targeted therapies, for example, in combination also with local radiotherapy, as we investigate in the EARN trial, is something that, for me at least, holds promise in this population.